Madam, I'm going to call upon our first speaker. I know it's a bit boring. Are you guys awake? Can I have an applause? Are you guys awake? Just into the last session, right? We're going to call upon Dr. Shehbaz Kasi, somebody I've known for years, a person who really knows his thing, right? He's a guy who's really worked on nutrition. Did he just run away? Shehbaz, are you here? He was here. He was here. Right? All right. So Shehbaz will be up to his bit. He's going to be talking about preoperative components and enhanced recovery after bariatric surgery. So we're going to listen a bit about that and get bored for a few minutes more. Did he go to the toilet? A big round of applause. Thank you for the delay. 2 minutes late.
Assalamu alaikum. Wanted to build up the excitement. Thank you, Ji. Are we connected?
Before Shehbaz starts, I want to say nobody knows more than about clinical nutrition than him in Pakistan.
Ladies and gentlemen, Bismillah ar-Rahman ar-Rahim. Thank you for this honor. I am glad to be amongst teachers and colleagues. Today, my topic is enhanced recovery after bariatric surgery, or the ERABS protocol. The protocol is designed to change how we manage bariatric patients with the goal of faster recovery and fewer complications. Ladies and gentlemen, mark your calendars for the upcoming event. Inshallah, we will meet on the 25th and 26th of October in Islamabad. So, what is the problem? The problem is that we have a pandemic at our hands. Dear God. We have a pandemic at our hands. About 1 billion cases of obesity and about 700,000 bariatric procedures offered every year. Now, before performing any of these procedures, we should have our patients optimized for such procedures. And that's where the ERABS comes in. The enhanced recovery after bariatric surgery starts before the bariatric surgery even happens. Very few of us are from the era where self-adhesive, disposable bandages or dressings were not available. And every surgical ward used to be like the National Museum of Cairo. Everyone was wrapped in linen from head to toe. Then came in adhesive bandaging and our wound care improved. Similarly, our post-op management of patients used to take a lot of time. That used to put additional economic burden on our already meager resources. So in a country like Pakistan, where the resources are already limited, obese patients require more resources in terms of dosage per kg body weight and in terms of manpower required to handle them, move them and mobilize them. And so, the ERABS protocol is designed to reduce all of that. The conventional stay being from 4 to 5 days if you consider an open bypass, to bariatric surgery where you're doing a lot but you're doing it with a minimally invasive technique, we tend to reduce that time. My aim is to tell you how to reduce it even further. So, Something's off. Ah, yes, here we are. Ji. Thank you. So there are three pillars of ERABS. Prepare before the surgery, minimize the stress during surgery, and accelerate recovery after surgery. But sir, all of this only works when we do it as a team. Now, in the past 1 year, since I've developed a team of my own, I have never, as a surgeon, seen a single patient on his first visit. All of them are seen by my clinical nutritionist, who happens to be me. Sorry. And I have a clinical psychologist. Every patient of mine, 100% of my patients are seen by a clinical psychologist, and they are assessed for any loss of control eating or any other eating disorders like binge eating disorders. And we are following currently the EDEQ6 guidelines for the loss of control eating disorder or any other disorders that we might consider in these patients. And before they go on to table, we have to identify if they have an eating disorder in order to make sure that our surgery is successful in the long term. We also have an endocrinologist on board who assesses for any endocrine disorders prior to surgery. So, what to do preoperatively? This is something we surgeons have either never learnt or we never try learning. Talk to your patient while he's awake. So, the first thing is sit down and talk to him what to expect before the surgery, what to expect during the preparation for surgery, and what to expect in the short term after surgery, in the first few days to the first few months, and then the first few years of surgery. Ensure that the patient knows that he has to have an extensive follow-up before the surgery even happens. Then, optimized fasting. We do not believe in liquid diets or bowel purging or anything else. We consider solids to be stopped 6 hours prior, a fat-free diet for the last 1 or 2 days so that the bowel is lighter, the lymphatics are less pronounced, so the bowel is less slippery and there is less trauma during the mobilization. Secondly, carb loading for the non-diabetic patients. We do it sometimes, mostly we don't. Though the guidelines tell us about the VTE prophylaxis, we don't do it. We have pneumatic compression devices which we apply to the patient during the surgery, and we encourage the patient to get out of bed within 3 hours. There is no point in keeping a patient on bed when he has not had any limb surgery. Ulcer prophylaxis and antibiotic prophylaxis is given on table. Comorbids are controlled in the preoperative period that may span between 2 weeks and 2 months. We've had the severely resistant hypertensives that do not respond to any medications, but they do respond to a mild to moderate weight loss along with good medical therapy. So, peroperatively, when the anesthetist assesses our patients, we usually recommend total intravenous anesthesia, reduces post-operative nausea and vomiting, along with early mobilization. Gas anesthesia, from our initial days when we used to do sleeve in our department, what used to happen was the surgery would start at 9, and it would end at say 10:30, and then till 3 p.m. we would be sitting by the side of the patient praying to God that he would wake up because he had had gas anesthesia, and until it left his system we couldn't leave the OR. Thank God for total intravenous anesthesia, and credit goes to Dr. Robert Rutledge, who came in and insisted on TIVA. Our anesthetists never were amenable to that change until he came in. Then, fluid management. We do not believe in overhydrating our patient. Just enough liquids so that he can maintain BP per op. That's it. No overloads. Again, analgesia, opioid sparing. We do not believe in giving NSAIDs. And per-operatively, tab blocks are given under camera vision so that we have a good post-operative pain-free period. IV paracetamol, which is switched to oral paracetamol within 12 hours once the patient is broken NPO and is tolerating orally. The surgical technique, of course, laparoscopic surgery has made upper GI surgery revolutionary amongst other things, and we do not place drains. One of my teachers used to say the drain is for the surgeon, not for the patient. So one way of avoiding those drains is becoming a better surgeon, and the second is by doing a better pre-op. Thank you. Again, lot of pain, foreign body, causes infections. If it can be avoided, please avoid it at all costs. Post-operatively, your patient has to be mobilized as soon as he's awake. The advantage of TIVA is that the half-life of propofol is 5 minutes. So if your patient has 2 working limbs, he should be up and about within 3 hours. We start liquid diet 4 to 6 hours after surgery, and then if tolerating, we can give very small portions of soft solids. Again, the guidelines do suggest that low molecular weight heparin reduces mortality in the long run, but it has also contributed to staple line bleeds. So if our patient is mobile, we don't do anything. PCD is good enough. We do not catheterize our patients. We tell them to go to the washroom prior to surgery, and that's it. And we tell them to go to the washroom after surgery. So there's no point. Again, if your patient has 2 limbs, he should be able to walk to the bathroom. Thank you. So what is the criteria of a discharge? When should you send your patient home? If he's awake, he's conscious, he's tolerating, you see no if he's tolerating orally, basically if he is in the same status plus surgery when he came in, that's when he goes out. Follow-up. We are very extensive about follow-up. We want the patient to visit on day 5, day 14, first month, third month, 6th month, 12th month, and then annually. The nutritionist has a 3-monthly follow-up with the patient, so I get to see the patient every 3 months.
Shehbaz,
Ji.
couple of minutes.
Sorry, sir?
Couple of minutes more.
Sir, I'm almost done, sir. Thank you so much. Ranahir dekho. Yeah. So when the honeymoon period is over, the first 6 months, you've got to see whether or not the patient is developing any macro or micronutrient deficiency. Protein and micronutrients have to be followed up regularly. We send annual 6-monthly micronutrient levels, then we switch to annual levels of micronutrients, and that's it. If the patient is taking them, good enough. Sometimes we have to supplement IV iron in a very few patients, but other than that, alhamdulillah, no issues. Patients have to be educated on red flags. Tachycardia, not coming below 120, high-grade fever, abdominal pain, signs of peritonitis. You have to educate the patient to come into the hospital the minute they get these symptoms. So, summarizing that, the proven outcomes of the ERABs is that it reduces length of stay, decreases the requirement of opioid analgesia, increases patient satisfaction and confidence in the surgeon, decreases the overall costs, decreases the overall incidence of complications, readmission rate decreases, and sir, it's a safe, feasible procedure. Protocol, sorry. In the end, I would just like to say that bariatric surgery is a teamwork. My last message to the surgeons is, don't try too hard to be heroes. You're already one. Just focus on making a team. Thank you so much, ji. Assalamu alaikum. Any questions, ji?